We're running actually quite a bit behind schedule, so a couple things. We'll do the panel. I think this is a very important session. I think there's a lot of questions here, so if you have questions, please come up to the microphones right now. But just housekeeping notes. We'll do the panel discussion up until 12:15, so about 10 minutes. Then we'll take lunch till 12:55. We will not take a break between sessions 3 and 4. And then we do not need to do a group photo. So I promise you we will end on time. Okay, so with that, let's go ahead and start with the panel discussion. Question over here.
Yes, so a quick question on the AI talk. Thank you for the presentation. It was excellent, eye-opening to see this. The question is about going from a research paper to large-scale deployment. And we usually see first step is publish a paper. Then it would take a lot more work and make it complete to be deployed. So I'm just curious, in the presentation you had, what would it take to be practical?
Yeah, thank you very much for your question. In the United States, so we don't have any devices available for the AI. And so, as I briefly mentioned, so AI need to learn a certain disease. So the current upper AI model is still detect early gastric cancer, but not GIM or atrophy. So there's a couple questions. One is if we can just bring the AI model, which was developed, the AI learned from Japanese people's stomach, that was applicable for our U.S. population. That's the question number one. Number two is if that is okay, so we still need to, if we need to validate to use the device to our population before commercially available. So I think there's a couple of the area we need to improve. And then so speaking about the higher risk screening, so we don't care about advanced cancer because we don't miss advanced cancer. So AI need for detect early cancer. So if we need to develop AI in our country, we need to collect good quality early gastric cancer video and images within the United States. So that is also challenging. So I think we are still discussing how we can move from here. So literature was published in high-risk region, China, Japan, Korea, to the U.S. level.
But even in Japan and China, were these models actually deployed in practice? People actually widely using it, or it's just at the stage of publishing paper?
To my knowledge, so Japan is commercially available. So the clinic and endoscopy clinic and hospital, they're currently using AI in real clinical practice. I think that's also true for China as well.
Go ahead, Xiaozhi.
Thank you. Wonderful session. So congratulations to all the speakers. I had several questions, but I'll limit it to 3 for Dr. Gerhard. We clearly saw very nicely the age difference with that cutoff of 45 years old. Did you have baseline histology in terms of OLGIM scores? Because we know that, with the duration of H. pylori infection, that more severe histology.
Unfortunately, in this study, we were not able to perform endoscopy at all, not within the study. So we came up with these questions sort of in the middle of the study, and then we started a nested trial in which only 20,000 participants are included, screened, and they are all undergoing repetitive endoscopy over the course of 12 years. That's still ongoing. Yeah. But here we couldn't do any endoscopies. They were done at an individual basis when the patients would go seek advice for symptoms, but we don't have access to these data since it was outside the trial.
I see. And kind of follow-up question, so that does explain, because you had shown very nicely that there might be this trend toward esophageal cancer, and maybe it's because of training detection. Do you think that might, though, also be in those patients who did fail eradication? You're still going to have that effect of improved detection. So we certainly know there are microbiome changes and those aspects, and we've seen that with other studies with antibiotics. But do you think that improved detection might also explain that?
We'd have to look into that. It's a very good point. You can imagine that the amount of data we have to deal with is huge. So we're still in the sub-analysis of all these subgroups and different parameters. We haven't completed that yet. Yeah, but I'll take it back to Beijing and discuss it with them.
The consequence of doing a wonderful trial. Congratulations.
John.
There we go. Try to keep, yeah. Joo Ha, you talk a lot about what the purpose is, which is really get people screened, or rather screening to then reduce gastric cancer incidence and mortality. One of the big barriers, of course, is payment and reimbursement. One way to make sure that you get payment reimbursement is USPSTF grade A or B, and therefore CMS will waive copay. So all these things are going, the parallels to colon cancer. So here, my comment is, we really do need screening studies, and I still think we need a screening study in the US. And the issue is it's not just randomizing people who have HP, but rather screening for HP. And Dr. Kumar, this is kind of directed to you. You really nicely illustrated all these barriers. It's really not testing screening, but rather testing an invitation to screen. And then you get the whole mess of the adherence part. I was intrigued by your idea that, yeah, actually a lot of things require tailoring to be able to increase adherence. Once you start tailoring, though, then you reduce generalizability. So trying to keep this forward. How are we going to do this? And particularly, can we do this in a quasi-randomized trial where you randomize it by site, and then each site can actually have some tailoring, whether it be a church-based outreach or whether it's I was going to say, in colon cancer and the African American community, it's a barbershop, focused kind of intervention. That's gone great. So I'm just trying to figure out how we're going to address adherence and uptake of screening in a randomized trial of an invitation to screen. That's my overall kind of thought, and that's what I think we need to get if we're ever going to get USPSTF A or B.
Yeah, absolutely. And I think the challenge is real. There are parallels to colon cancer screening, and when you think about what Cologuard did, and they opened a 24/7 patient navigation line, you could go to them for financial advice, you could go to them for questions, and it was completely available. I think that is lofty for H. pylori, mainly because the numbers are not as large. But I think getting some investment from industry to do something like that would be helpful. I do think it needs to be culturally tailored. I was speaking with Dr. Eppeline, and we talked about the differences in our areas. So in Miami, people are really willing to undergo H. pylori screening. Usually when they see me in clinic, they talk about H. pylori first. When I was in Philadelphia, no one knew what H. pylori was. And I imagine it's something different here. And so part of this is that we do need different studies across the country. And I don't think what I do in Miami is going to be applicable to every single subgroup. And I think even within, say, Native Americans, there are differences. The Seminoles are a very wealthy, a very well-connected tribe. And if you compare it to tribes in Arizona, they have a lot of barriers to cancer care. And so I think it's a really unique challenge. And I think the other thing that makes it more unique is that it's a multi-step. And so obviously colonoscopy or FIT testing is multi-step. You have to tandem it to something. But for us, it's as you say, it's test and treat. So I'm not sure I have great answers, but I do think there's value in behavioral health strategies. I think community engagement is really important. And I think, I imagine something like this summit will start to move towards implementation strategies in the near future.
Thanks.
Eunjung, I wanted to ask you a question since you're here. I have two questions for you. One, a speaker, an attending yesterday raised an interesting issue regarding South Asians and missing data. And if you look at your graphs, the South Asian population has almost an unbelievably low risk of gastric cancer, and we know that they have a high rate of H. pylori. So do you think that, that's falsely low, that we're just not capturing that data? Because, again, Shalja mentioned that, South Asians have a tendency to go home to die, and so we don't capture any of that information. And then the second question is, why are we, you showed a lot of great data on foreign-born and U.S.-born, but they're missing for the Koreans and the Vietnamese. So why is that data missing?
So the second question is more simple. So the second question, we have to suppress any count that's less than a certain number. So we had to hide the number. So that's why those are missing. And then about South Asian data, it's always possible that the data may be just false. So that's a possibility. But the low gastric cancer in South Asians may be true because we see they have very high instance of other diseases, so like cardiovascular disease. So it is difficult to imagine only cancer registry is not picking up South Asians if they have gastric cancer.
All right, with that, okay, Aki, sorry.
I have one question. As the only non-doctor in this room, patient advocate here, I want to know what this means. I see all this data. It's interesting. I'm 30. I was 36 when I eradicated H. pylori. I'm now 42. What does this mean? What does this mean for me? What does this mean for patients? What does this mean?
You want to comment? That's a good question. You're the senior one right here. You have more gray hair than I do.
I completely agree. I think we need lots more patient advocacies, and I think similarly on our medical and scientific communities, more efforts in translating the content and messaging into what laymen can easily understand. So lots more efforts are required on that.
I have an answer. Okay, thanks so much. And they're going to, the parallel again is colon cancer screening, and it's been alluded to that as part of my role when I was in the AGA, we actually were able to eliminate cost sharing for the colonoscopy after FIT. And it wasn't because a bunch of pointy-headed people in academic centers went to Congress. And it turns out we had to talk to CMS, we talked to Department of Labor, we talked to Health and Human Services, and even the treasurer in the IRS. That's who I had to testify with, which is a little nuts, right? But it was because we worked with the patient advocacy groups, Fight CRC. These are patient families, horrible stories, young people dying of colon cancer, and then the American Cancer Society. And the reason they listened to the doctors is because there was the compelling stories of the patient advocates. We didn't get this passed, we didn't get the co-pays done because of us. We had the data, but it was the compelling stories. That's a connection. So I would say, what does it mean? It means that, again, if we have the data, if we have screening data, we show that hopefully in the US, that screening can reduce gastric cancer incidence mortality. It'll require congressional kind of approval, and that'll become, and that is achieved because we have patient advocacy groups like yourself and your groups, as well as, let's say, other organizations like the American Cancer Society, supported but not driven by the data from the science. That's what it means, and that coalition is what's necessary to really actually make an impact and get screening done like we're trying to do in colon cancer. Thanks.
Dr. Jones.
Can I just do a follow-up?
Yeah.
Just to follow up on Aki's question. So Young-hee and I were going to try to organize a separate lunchroom to discuss follow-up advocacy strategies to help folks in the audience to attend, in particular, the Hope for Cancer Advocacy Summit in February. I think because it's such a short time, maybe we can just whoever's interested in it, just come to this table right by the microphone at lunchtime, and we can see if you want to engage and how we can help support you in doing that. Thanks.
One quick last comment, Dr. Jung.
Yeah, very quick comment and question. Dr. Lee, the localized stage in Korean American is very high, right? So what is one of the reasons why the Korean Americans stage is very lower is the touring to Korea for the health examination. So how's the other countries like Japanese in the past? Is there a similar phenomenon was there?
That's very true. Thank you for the comment. And I think there is some miscount of those localized diseases because of the medical tourism. So that will be happen. Another thing is, unless they go back to Korea, never come back to US, we have a mechanism to pick them up in the cancer registry. But yeah, that's very true. We will lose some people, but many of them will be picked up. And when we did the survey, interview studies among gastric cancer patients among Koreans, the vast majority of them are actually diagnosed in the United States. So I think so we know that many of them are doing medical tourism and diagnosed in Korea. Maybe those are the relatively younger, healthier before they develop the cancer. The vast majority of diagnoses were actually made in the United States, in Lake County. Thank you.
All right, thank you, everyone. Let's one last applause for the speakers.